So I will keep admitting people as they come in.
Thank you, everyone.
Brilliant. Yes, thank you. Excuse the slight tech issue. So we have got that up and going, which is great. So introductions. My name is Philippa Oakley. My pronouns are she and her. I will introduce myself and then I'll let Rhiannon introduce herself. So I'm a qualified chiropractor. I've been in practice for 10 years now. Magically haven't aged a day in that time, of course. So my background is in clinical practice, supporting people with pain management in particular has been a particular area of interest for me. In 2016, Rhiannon and I trained as coaches alongside our clinical practice, and we did that because we recognised that some of the training, naturally, the undergraduate curriculums for many medical degrees, they just don't have enough time or scope to focus on things like psychosocial issues and things like that. So we dual qualified as coaches alongside that, and since then we've been very lucky to really have a lot of opportunities come our way, which we've kind of taken advantage of. We work with the NHS with a lot of ICSs and trusts, delivering clinical training as well as inclusivity training, training on unconscious bias, for example, or the new way that we prefer to phrase it is conscious inclusion training. And we're married, clearly. We have two beautiful daughters. We have Clover, who is with us, and we have Wren, who is Clover's twin, who was sadly lost during the pregnancy. And it was part of our experiences going through that as well that gave us the lived experiences of what so many people go through when they're seeking healthcare. From our perspective as members of the LGBT community, obviously we have our own lived experiences coupled with clinical training and clinical understanding. But we've really taken that and grown alongside the community, expanded our network to hear more about other people's experiences, to focus more on EDI, inclusive language and communication skills, which is what brings us here this evening.
Yes. So my name is Rhiannon Oakley and my pronouns are she and her. So my background is business development and marketing, and we trained we certified our personal performance coaching at the same time. My sort of focus originally was working with patients with health coaching, and it developed into also helping clinicians work on their businesses and training them with communication skills. And I've recently become a trustee of the Chiropractic Research Council, so it's very exciting.
Yeah, so that's us. So we are here tonight to talk to you about the impact of inclusive language in healthcare. Just a quick trigger warning, because some of what we might get into, I don't know if we will, but in case it comes up, there may be discussions of homophobia, transphobia, and similar. As Rhiannon's mentioned, we want to make sure that this is really inclusive space, make sure that this is a positive event. So in order to achieve this, we do ask that everybody's respectful of everybody else and that we're respectful of each other's opinions. And that we try to all contribute constructively. We recognise, and it's really important to us when we do these seminars, that we create a safe space, because I think that so many of the challenges that surround inclusive communication and inclusive language are, which we'll talk about, but the fear of offending somebody, the fear of getting it wrong, the fear of making a mistake. And so we do welcome emails and questions and things like that to be sent to us if you don't feel comfortable posting in the chat, because we know none of us want to cause offence, but sometimes we have questions where it's a genuine question of, I don't know if this is offensive and I don't know how to learn if it's offensive or not. But do try and keep all questions to be constructive and respectful. And obviously we're all entitled to our own opinions on things. A brief overview of terminology. In the talk, we use the term transgender as an umbrella term for anybody who falls within that bracket, and cisgender to denote somebody who was born into a body that matches the sex that they were assigned at birth.
We may also say EDI, which is equality, diversity and inclusion.
Yeah. So just to keep abreast of acronyms, but we'll try and avoid those. So What is inclusive language? It is really important to recognise that effective communication, I think we can all establish this if we're clinicians or we're working in any kind of patient-facing or service user-facing role. Effective communication is at the heart of any healthcare consultation, and it is a true hallmark of patient-centred care or person-centred care, depending on which term you use. There are well-established and very significant links between effective communication and patient outcomes. And there are also really well-established links between inclusive language and inclusive communication and patient outcomes. Now, inclusive language, in trying to find a general definition, we've come up with a couple of things. We really like this quote that's on the computer in front of you, on the screen in front of you. But basically, inclusive language is a way of being respectful with our patients. It's a way of being accurate with the information that we have about who they are and their background. It's a way of being unbiased and being consistent with the preferences of our patients and their communities. Traditionally, when we talk about inclusive language, that used to be in terms of race and ethnicity, but it now extends towards other groups. So we have inclusive language towards older people. We have inclusive language of people from the LGBT community. We also have inclusive language in terms of communicating with people who have learning difficulties, for example. It's a really broad topic. We're going to attempt to do it justice in the hour that we've got with you this evening. But this is something that there's significantly more information about all of this in our online training courses, for example. So if you still have questions, then please do use those as a resource. Now, we've talked a little bit about why inclusive language matters and the importance of it in terms of patient care and patient outcomes. Now, for many of us as clinicians, we might think that actually simply communicating well is enough. And that actually, if we ask questions that might be we might consider them to be too personal, for example, to ask somebody about their ethnicity or to ask somebody about their sexual orientation or their gender identity, we might be concerned that actually that will create a barrier to the working alliance and the working relationship with our patients. But what we know is that poor communication between healthcare providers and their patients leads to distrust. And patients who don't feel heard and who don't feel understood, who aren't dealt with in an inclusive manner, will not share key information with us. When I'm working, and Rhiannon can nod here, but when I'm working with people who are in a clinical role, so they're working in a clinical capacity with their patients, it's often brought home when we recognise the impact that being non-inclusive can have on how much information we get from our case history and the impact that this can have on our clinical decision making. For example, to talk about LGBT patients, just as something to speak from our own lived experiences, if we are dealing with a patient who is transgender, so for example, a transmasculine patient, many patients who are transmasculine, in fact, the majority of patients who are transmasculine don't actually undergo any type of surgery. And the transitioning process is a journey and it's very individual for each person. For some people, transitioning may just involve social transitioning. It may involve simply changing the way that they express their gender, or it may involve hormonal interventions, or it may involve surgical interventions. Now, if we have a patient who is a transgender man who doesn't feel comfortable or doesn't feel able to share with us that they were assigned female at birth, and we don't capture that clinical information, there is a huge issue within the transgender community of patients not being referred on for cervical screening tests, of patients not being diagnosed correctly because we simply don't capture the information. We don't recognise that patient may have retained all of their natal organs, for example. So inclusive language and creating an inclusive environment, really importantly, creating an environment where our patients feel heard, they feel understood, and really importantly, that they feel safe to share information with us is absolutely vital from a clinical perspective. So this is not just something that's nice to do, it's something that we really need to do. It's also really important to touch upon the fact that there are established links between empathy and patient outcomes. The more empathic a provider is towards their patient, the better the patient's levels of satisfaction and the better the clinical outcome after care. So for somebody like myself working in private practice, where patient outcomes are vitally important for me, in terms of the work that I do, and keeping a roof over our heads, paying our electricity bills, it's really important that my patients are happy with the care that they receive. And of course, for people working within the NHS, we're constantly striving to improve our patient outcomes. So it is really, really important to bear in mind that inclusive language is not just something that's nice to do, it's something that is a hallmark of patient-centered care. If we are biased in the way that we care for our patients, if we stigmatize them inadvertently, if we can't connect with them, if we can't be empathic with them, then our patients will not feel comfortable sharing information. We miss clinical information. We perhaps don't build those strong working alliances that are the hallmarks of good outcomes from care. Being inclusive in our language towards our patients helps keep us patient-centered and keeps us focused on the needs of the individual. We're going to talk this evening about the challenges around inclusive language, why it's not as black and white as we might like it to be, or as it might be helpful to be. But hopefully by recognise that simply being patient-centered, focusing on the patient that you have in front of them and getting to know them and their story and their preferences and the way in which they communicate is being inclusive in your language towards them.
Listening is so important. So this is a fantastic resource that we have in some of our courses that focus on inclusion, and we would say that some of these terms and phrases, they're always developing, so this isn't a checklist, this isn't something that you need to memorize. It's something that is really helpful to understand what term to avoid and what term would be preferred, and why, and a great example as well. So this isn't the whole of it, so there is a larger PDF in the courses, and there's also others that include like plain language and things like that are really helpful. So still on this slide,
sorry.
It's not a fixed thing, as I say, so this does change. You do have patients that sort of are of the older generation, so from the 70s, 80s, they have particular terminology, and then what we would sort of deem sort of modern terminology. So it's, as Philippa was saying, really important to listen and learn from that unique patient right in front of you. There is no generic term that is acceptable anymore, really. So there is a great example in there. So avoid saying hermaphrodite. That's actually intersex now. That is the replacement word. And it's not always possible to get it right. Being inclusive and using inclusive language does involve a conscious decision to do that, and that's sort of where we're going on here, and that's why you're here at the moment. You've made a conscious decision to make that change.
So as Rhiannon has said, really important to bear in mind that this is not a checklist. So whilst we have this available as a resource, inclusive language is not a checklist. As she's quite rightly said, there is no right or wrong, because so many people will use terms that are entirely specific to them. For example, very recently I've been working with the NHS Rainbow Badges assessment programme, which is working with NHS trusts to look at the care that they deliver to LGBT service users, but also looking at things like staff-facing policies and procedures. And what we found is that actually people were coming in, for example, and a patient would present within the service and describe themselves as transsexual. So we had a patient, and it was described to us as the patient attended the service and described themselves as being transsexual. That is a term that actually we don't use nowadays. We don't use the term transsexual. The term is transgender. However, that was the term that the patient used to self-describe themselves. So in that situation, it is entirely appropriate to reflect the patient's language back at them. And that's really important, I think, particularly for us, for example, I am a homosexual cisgender woman, so I identify as female. I use she, her pronouns, but I'm homosexual. But I don't describe myself as being a lesbian. I describe myself as being gay. That's an example of me being comfortable with particular terminology that I use to describe myself. And it's entirely appropriate to listen to the terminology which somebody uses to describe themselves. We see this a lot within the Black and minority ethnic community, the BAME community, for example, where if somebody describes themselves as Black, it's entirely appropriate to use that language back. It would not necessarily be appropriate to refer to them as a person of colour. If they have self-described themselves as Black, it's really important that we listen into the language that our patients are using to talk about themselves, and to reflect that language back at them as providers. That is really the hallmark of inclusive language, is being patient-centered and using their own terminology to reflect it back at them. So, words can harm and words can hinder. I'm sorry, my slides are being really enthusiastic today. With inclusive language, it's not going to be comfortable. That's really important to bear in mind. It is never comfortable when we have grown up with language, with the way in which we speak and the way in which we communicate, being so deeply enmeshed in our own backgrounds, our own cultural experiences. When we then have to change the way in which we communicate with people, it can feel uncomfortable. It can feel unusual. For example, I know that we see this a lot when we're talking to people around pronouns, for example, aren't we? And that can be a significant issue. But what we don't want is for our own feelings of discomfort to stop us from attempting to be inclusive in our language. So don't allow feeling uncomfortable, feeling embarrassed, or feeling insecure to stop you from attempting to be inclusive. So, for example, not asking a patient what pronouns they use, or not asking a patient about ethnicity. We have this trade-off between temporarily saving ourselves a little bit of discomfort, but it negatively impacts the patient, and we can't have that. We can't have patients not suffering is the wrong word, but we can't see patients having negative clinical outcomes or see clinical outcomes impacted purely because we aren't comfortable with being uncomfortable. So, as Rhiannon said, it's not always possible to get this right. And the fear of causing upset, the fear of causing offence is something that is universal amongst everybody that we speak to, everyone that we speak to about inclusive language, about pronouns, about asking about surgical history, for example, in a transgender patient. Every single person that we speak to is worried about causing offence. So you're not alone if you are one of those people who is worried about causing offence by asking somebody these questions. But it's really important that that discomfort that we have, or that feeling of awkwardness, for example, in many cases, doesn't override the importance of delivering inclusive care.
And always keep it relevant. I mean, if it's just curiosity, perhaps just say it's curiosity and it's not relevant to their medical history. But that's actually a really good point that I'd forgotten there. Absolutely, is if it's not relevant, then we don't necessarily need to ask. So, Rhiannon, what do we do if we make a mistake? We say, I'm sorry, the most British thing we can possibly do. It's simple. If you make a mistake, just keep it, apologise, make it brief. Don't make it about yourself. Don't make a big deal out of it. Just, for example, say, oh, I'm sorry, I meant to say him, or I meant to say the real name, their real name, their new name. So as a clinician, it's really important to think about how, if you do make that mistake, how are you going to ensure it doesn't happen again? I mean, what do you need? Is there anything on your clinical notes that will help you remember for next time? Are the front of house staff aware? Do they need to know? Does your patient want the front of house staff to know? Do they want the front of house staff to say it in front of other patients? It's really important to make sure that that is a safe place for them to be themselves, where they want to be themselves as well. So how, so yes, using your notes to record it. There are some software and diary systems now that do ask for pronouns and all sorts of information like that, so you can gather it before that even speaking to someone. Be opening and welcoming of any corrections. So if they say, oh no, this is my pronoun, to say, oh, I'm sorry, I'm trying to do better here, and I really welcome correction, so thank you for saying that and correcting me. If you're corrected by someone else, try not to be defensive. It's a simple correction and a simple response of, again, thank you, and then repeat what you said before, but with the correct information, so their correct name or their correct pronoun, for example. And Philippa's got a really great example of this, actually.
I have many great examples purely because of the work that I do, but a prime example to show that, you know, even as somebody who works within this field of EDI, when I was working with the NHS Rainbow Badges, the team that we were working with, very quickly, within 2 weeks of starting, 2 members of the team had transitioned, and I was told only afterwards that the names that which I knew them by were their dead names. And dead name is the name that somebody who's transitioned, it's the name that they were given when they were before they transitioned, for example. So many people choose a new name for themselves that better describes who they are. And I saw one of my colleagues at the conference and I dead named them, which is something that is mortifying. I was embarrassed to realize that I'd done it, but actually we all do it. I think everybody feels embarrassed when you recognize that you've made a mistake, but the important thing, as we've talked about, is to simply say I'm sorry, and to acknowledge that you've made a mistake and that you're trying to do better, and to move on from there. So we all do it, and it's not something that should stop us. It is a temporary embarrassment. It's not reflective upon who you are as a person in many cases. And that's something that we consistently saw with the majority of the trust that we were working with, is that actually people within the trust recognize the importance of inclusive language. They recognize the importance of EDI training, for example. They recognize and acknowledge how vital it is to understand the cultural impacts of somebody's experiences with healthcare, of you know, recognizing that people have specific health needs. We need to meet and address those health needs, and we're all striving to do better. It's a very small fraction of people that we've found who are not on board with this, and it's something that I think shouldn't be overlooked in the context of talking about equality, diversity, inclusion, talking about EDI. Is that we do invariably stray into the realms of social justice. We stray into the conversations about transgenderism, for example, being a modern phenomena when it's not. You know, there are examples of people, you know, living in 3,000 years ago, for example. So that these aren't modern phenomena. It's just something that we now know more about and that we have more awareness about. So language and people are constantly evolving, and that makes inclusive language enormously challenging in many ways, and very nuanced as well. So here it might look like a list of words, but bear with me, because I'm going to go through and hopefully highlight why some inclusive language can be so challenging. So it's really important when you're working in clinical facing roles to try and stay abreast of language and changes within language as much as possible. A common theme that we explore throughout all of our training, in fact, is that the subtleties and nuances of inclusive language and patient-centered communication mean that really the safest way for us as clinicians to be inclusive and to communicate effectively is to purely focus, almost tunnel vision, on the patient in front of us, and almost disregard what we think we know or what we think we've been taught, because we need to
listen to the patient's self-descriptors. We need to listen to how that patient self-describes their gender identity, their cultural background, who is close to them within their family, how they describe their family unit. Rhiannon was talking earlier, one of the examples that came up on that inclusive language resource is not asking people about mother and father, for example, because some children, like our daughter, for example, her parental unit is 2 mothers. So if somebody asked about her father, immediately that's non-inclusive language. But we also see this within people who, perhaps have refugees, for example, within the traveller community, or people who've come asylum seekers, for example. We're seeing that now increasingly. Some of the people that we were talking to were saying they ask about family units, and actually their family unit might no longer be available to them. They might be back in the Ukraine. Somebody was saying recently that their family was left at home in the Ukraine. So when somebody asks about their next of kin, as a medical contact, their next of kin is not somebody who's going to be available to them. So asking about next of kin, we're actually much better to ask for who is your emergency contact, who would you like us to contact in the event of an emergency, rather than who is your next of kin. Similarly, in the LGBT community, some people, for example, who have come out to their families and unfortunately their families have rejected them, they create their own families, they surround themselves with friends, and so their next of kin might be a friend as opposed to a blood relative. So that's another example of the subtleties that are often presented in this topic.
But even that reminds me of that case study where the gentleman was in a care home and he had Alzheimer's. No, he was in hospital with Alzheimer's though, and his husband, his long-term partner, was not allowed to visit him because they weren't married, and the family weren't. I can't remember the reasons behind it though. Do you remember that?
Yes, yeah, I remember that one as a descriptor. The patient, to use the names that it's not their actual names, but it's the names that we anonymise them to. The patient was called Nicholas. The patient was married, and the patient's husband was called Chris. Chris called up to ask for information about Nicholas and was told that they weren't allowed to share the information with him because they didn't realise that Chris was the patient's husband and not, just a random person who's calling up. So there are real life examples of this happening and of people being non-inclusive in their language and the impact that has on patient care. So let's look at deaf and deaf, for example. I've never worked out how to actually how to verbally make it clear that I'm talking about deaf with a lowercase d or deaf with a capital D.
See who's watching.
So deaf as a lowercase, it tends to be used for people who have severe hearing loss or for anybody who falls within the spectrum of being deaf. Whereas people who've been deaf all their lives may prefer to use deaf with a capital D to denote that they are somebody who has never been hearing. That indicates a really important distinction between person first language and identity first language. So person first language would be to refer to somebody and say it's a person who is deaf, whereas identity first language would be to say a deaf person. Identity first language is often preferred with, for example, a deaf individual or autistic people. But it's really, really important to bear in mind that actually we cannot make assumptions about that, and invariably it will be offensive to someone. We find this if you start looking at the disabled community or people who are living with disabilities. There is no general consensus between the way in which we should talk about people. We don't refer to people as being wheelchair bound, for example, anymore. We definitely don't do that. We talk about people being wheelchair users. The same way we don't tend to refer to disabled people. We might say a person with a disability. And we see this consistently played out quite often in terms of the way in which people are described. So we might say somebody is a dementia sufferer or somebody is a stroke victim. And these are the subtleties of language that we perhaps have we've been using throughout our professional careers, or historically that's the way in which that used to be described.
but we don't use that language anymore. We don't, not everybody who uses a wheelchair is wheelchair bound. Not everybody who has dementia suffers from dementia. Not everybody who's had a stroke is a victim. So we need to think about where that language originated from. Is that something that we've simply been taught to use? Or is it something that actually is quite marginalizing for those people? When we were preparing this talk, we were looking into kind of some research around this and looking at what the latest evidence said. And an interesting one that came up for me was talking about drug abusers. So we used to talk about drug abusers, we used to talk about alcoholics, very, very descriptive in terms of aligning somebody as, an alcoholic, and that person, it becomes their identity, as opposed to it being somebody who is misusing alcohol or misusing drugs. So that's where we tend to talk about things. And even the changes in inclusive language around saying that somebody is clean, somebody is no longer using drugs, is somebody who's clean. When we stop and think about that language, and we think about the way in which we're describing somebody, they're saying that they're clean, and therefore if they're not clean, they're dirty. It's an awful way to describe somebody when we think about it. But this is the challenges with inclusive language, in the way that it is so deeply embedded, not only in our cultures, but also in our training that we've had as healthcare providers, in the way in which our families might have referred to people and what we might have grown up hearing. And we are now talking about using inclusive language and changing the way in which many of us have only ever known how to communicate. So quite clearly, it's not going to be possible to get it right 100% of the time. We can sometimes also make inadvertent assumptions, and I'll just make sure that I'm on the right bullet point here. We can sometimes make inadvertent assumptions as well with the descriptive terms that a patient might use to describe themselves. And this is something that whenever I talk to people about, there's normally a few minds that are blown when I say that, actually, as an example, not all men who have sexual intercourse or who engage in sexual activity with other men describe themselves as gay. And I can't tell you the amount of scenarios we've had where a patient has come in and they've explained their recent sexual activity, and the clinician has inadvertently, through the rest of the conversation, said something along the lines of, how long have you been in a homosexual relationship? Or, okay, so, and they've referred to that patient as gay. And the patient would not describe themselves as gay. So talking earlier about the way in which I describe myself as gay, but I don't tend to describe myself as a lesbian. Sexual behavior doesn't necessarily align with sexual identity, and it's really important in our language to not confuse those things and not make those inadvertent assumptions. So that's something to bear in mind. We also see with a lot of inclusive language nowadays, which I think you were talking about earlier, in terms of the kind of modernisms that have crept into inclusive language. Speaking recently to an older family member, I used the term queer, and I was describing our one of the co-authors on our LGBT inclusive training is Anna, who would self-describe themselves as being queer, as being gender queer. Now, my family member said, and looked aghast, looked pretty horrified by the fact that I'd use the term queer, because of course, when they were growing up, the term queer was derogatory. It was a really, really offensive term, but actually within the community, that term is now being reclaimed. And again, this is something that we see not just within the LGBT community, although we do tend to focus on that because it's what we know and it's our background. But the reclaiming of offensive terms is something that means that actually some language now we might consider to be offensive because of what we've always known it to be, but there is this move now to reclaim the language within the community. So again, much as I was talking earlier about a transsexual patient and echoing that language back to them, if a patient self-describes themselves as queer, it is perfectly appropriate as a clinician, and in fact advised in many cases, to use their own descriptive term back at them. Because if, for example, somebody described me as a lesbian, I would probably have a moment of recoil because it's an unfamiliar way in which I describe themselves and it doesn't align with how I feel. So just to talk about my own personal experiences there. Consider as well using the terms that we use within healthcare as well. Do you remember when we used to walk into maternity clinics and everything was pink, which is fine if you're somebody who likes pink, but it's not very inclusive. So one thing that we actively encourage people to do is to look at their services. So if you're somebody who's working within a trust, for example, and you have a maternity unit, could that be a perinatal unit instead? For example, we're currently working on some training that is on chest feeding. So no longer using the term breastfeeding, but using chest feeding. So we're working on developing some training for inclusive chest feeding. Because the language that we use, again, if you are somebody who is a trans female or trans masculine, you're walking into a clinic room that is entirely pink, and walking into a maternity service, you're automatically going to be concerned about being misgendered. You might be concerned about being inadvertently outed in some way. You might also worry that your medical needs aren't going to be met. And this is something, when you look at the impact of maternity care for people from the Black and minority ethnic community, particularly looking at the mortality rates for Black women, for example, we see that we don't yet deliver inclusive care across any spectrum. It's not just the LGBT community, it is for Black and minority ethnic communities, it is for the elderly community. This is something that we'd like to think that we're doing well. We'd really like to think that equality, diversity and inclusion is well embedded and is at the core of everything that we do, but it's not. We have so far still to come, which is why we're glad that you're all here this evening. We've talked a little bit about the biases that we might show when we're using when we're in some of the language that we might use, and how we can other people. If you are, for example, describing somebody as being non-white, or you're talking about somebody who is not disabled, that might show a bias towards the white community and the disabled community. And it's really interesting with biases, with unconscious biases, we all have them. So an unconscious bias is something that changes the way in which we might think about somebody. It might automatically prejudice us. It might mean that we've already stereotyped that person. So for example, just as I'm sitting here, if I said to you that you're caring for a patient from the traveller community, think what automatically comes up for you. You don't have to share it, but just think about what comes up for you when you think about the traveller community. Those are your unconscious biases. And we sometimes see those biases reflected in the language that we use. So when we talk about, when we describe somebody as being non-white, that's a biased language, and we need to think about the way in which we're stigmatizing people who are from a Black minority ethnic community when we're using those kind of terms. So we are going to leave you with some tips in terms of things that you can do and things to practice in clinic, whether you're in a patient-facing role or whether you're somebody who's working behind the scenes, for example. You have a fantastic one that we've actually done in our house that works really well for using pronouns, if you'd like to share that
so we have a toddler, and we actually name some of her teddies with various pronouns. This is Fudge, she, they. You can also, so you can practice that and then also embed that inclusion in your children as well. But you can also mix up pronouns in stories as well when you're reading them, which is a really nice, fun way of doing it as well. Also practicing as well with when that person is not in the room, just taking a moment before you say that pronoun as well, so you make sure you get it right. I know that when we get stressed, when we get busy, it's really important just to take that moment and get it right rather than making that mistake. It's much better.
So practicing is really, it is the only way to get comfortable with some of this language and some of this terminology.
Yeah, make it sort of a second nature, really.
Yeah, absolutely. And I was talking to a coachee recently who said they've got a team member who has started using they them pronouns, and we were talking about this person, and they said, oh, I feel rude when I refer to they and them. It doesn't feel right. It feels It feels like I'm going to be causing offense to them if I say they them. Shall I go and make them a cup of tea? It's like they're not in the room. And it really brought home to me that whole concept of becoming comfortable with feeling uncomfortable, because this practice manager, she was quite fairly saying, I'm worried about offending them. I'm worried about, upsetting them in some way by using the pronouns that they now use. And I said, just sit with that for a minute and just think about what you're saying there, because actually, although you might feel uncomfortable, you are using the pronouns that they have chosen for themselves. So there is no possible way that could ever be rude. And so really practice using pronouns, practice saying they them in the context of a singular. So, for example, dear old Fudge here, Fudge, have we put them to bed? Does Fudge need their mane and tail grooming? It's a fantastic way. It's a silly way, but it's a really fantastic way to start embedding and making it fun, for example. And really, the more that you do it, the more it will become second nature to you.
You've got like sort of a team mascot or something in your in your spaces or something.
Make them gender neutral and with a really culturally diverse background, so that you can really practice all of these inclusive techniques.
And we were just speaking to someone who works with at university today, and we were talking about a pronoun circle, actually. It's a really great way of introducing and making that a really inclusive space for someone to feel safe to
share their own pronouns
exactly. And their identity.
Hence why we start everything, we include our pronouns on everything now, because it then makes it safe for other people to include their pronouns. And speaking of pronouns, if you're somebody who uses pronouns that are traditionally associated with the gender that you were assigned at, the sex that you were assigned at birth, so if, for example, you identify as female, you use she her pronouns, it detracts nothing from me, from Rhiannon, who uses she her pronouns. It detracts nothing from us to be respectful and to use somebody else's pronouns, but for that person, for that individual, it means everything to them. So if you're somebody who thinks, I don't understand this whole pronoun thing, I don't understand the importance of it, just take a minute and think about how much it impacts you, really, versus how much it would support that person to use their pronouns, for example. Pronouns, again, have been around for a lot longer than we might be aware of. It's just that now they have much more visibility. There's now this move towards recognizing that people might not fall into the she her and he him bracket, and so we see more descriptive terms coming out. We see neopronouns emerging, so zir, for example, and Latinx. So instead of Latino, we see Latinx. If you are speaking to a patient who uses English as a first language, it's sometimes easier to use the pronouns that we have within the English spectrum, because we don't have gendered nouns, for example. We don't have, in the same way as Spanish have, a table, for example, might be male, or we might see, I'm trying to think of an example.
Well, there might be someone, it might actually make someone's life much easier who has a non-gendered name like Sam.
Or, using
like that, then the people who aren't sure what gender that person is, then at least they know that when the pronouns are up there.
So I actually find it easier now in many ways to say they them when I'm talking about the majority of people, so I use they them pronouns for the majority. And the same, I find this consistently, if you're somebody like myself who gets to know their patients, spends a lot of time with patients, if somebody refers to their partner, my patients' partners are always they them now until I'm told otherwise. Because we do see a lot of heteronormative assumptions being made. So using they them pronouns to describe anybody who you don't know whether they're male or female, or which sex they are, it's just a really, really easy way to start embedding that into your own language. When we think as well about the impact of being non-inclusive and microaggressions, so microaggressions are those subtle subtle slips of language that can occur that actually have an impact on patients' health outcomes. So, for example, saying to somebody, oh, you don't look black, or you don't look like a lesbian. Those are little microaggressions. And there's a fantastic video that describes microaggressions as mosquito bites. And some people might get one mosquito bite where it's a little bit annoying, and it's a bit irritating for a while, but it's not that much of an issue. Whereas some people who come from communities who face real health inequalities, who have massive intersectional issues, for example, so people who are black and gay, so they have the intersectionality between being a black person and being a gay person, that person might suffer repeated microaggressions. They might suffer racist microaggressions as well as gay microaggressions. So if you think of a microaggression as being like a mosquito bite, they're repeatedly getting stung by mosquitoes. And if you're stung by mosquitoes all day, every day, they're going to get a little bit annoying. So this is why it
affects mental health,
yes,
obviously.
massively. So this is why we talk about inclusive language, the importance of inclusive language, because microaggressions and non-inclusive language do have a well-defined impact on patients' health outcomes and their health trajectories. When we look at the impact of racism on health trajectories, when we look at the impact of heteronormative assumptions and non-inclusive care of the LGBT community on health trajectories, we see that actually inclusive language is one small part of our EDI toolkit, but it's a really, really important one. Now, to kind of continue in that vein, inclusive language is one small part of being inclusive, but it's not going to meet that entire package. And this is something that we consistently say is equality, diversity, and inclusion is an active and ongoing process. There is no way that you can tick a box and say that you are now EDI compliant, for example. It is an active and ongoing thing. The language is constantly evolving, the language is constantly changing. So the best thing that we can do is look for resources and look for places where we can keep abreast of what's going on. This is, for example, why our courses on this topic are lifetime access, because we constantly go in and tweak things, because it is constantly changing, it's constantly evolving. There is new research that's coming out all the time. Another top tip is approaching patients with curiosity. So hopefully we've kind of drummed in from this evening the fact that the best way to be inclusive is to be curious about the patient in front of us, is to ask questions, is to say, my name's Philippa, I use she, her pronouns, what are your pronouns? Is to ask the questions and say, and to find out more about them, and to make sure that this is reflected in our clinical notes, as Rhiannon touched upon. So making sure that it is documented, that other members of your team are aware of this descriptive language, and to use that language back at them. And be willing to be uncomfortable and to be corrected. Don't be defensive about it. It's not about you. If you make a mistake, if you are corrected, if you use non-inclusive language, apologize and move on. On that note, I'll move on myself.
So as Philippa was saying, it's all updating. We do have several courses that will help you become more inclusive practitioners and clinicians. And for example, we've got the conscious inclusion course, short course, couple of hours or so, and an introduction to inclusion, inclusive language. We've actually bundled these temporarily at a discounted price, and you can find those on our website. It's up there, oakleycoach.com /learn. And we just really want to help you raise your awareness of those unhelpful thoughts, ways in which you can change those behaviours and create that lasting and positive sort of behaviour change to enhance those patient encounters. And that's where sort of our communication skills course as well, really comprehensive course there. That will take you a lot more than an hour. And you can see all the full details on there. But that's where most of our training with the NHS and clinicians and institutions really focuses on, is communication skills specifically for people who are working in healthcare.
It's we've talked about this evening, but we've talked about the fact that it's all well and good being familiar with things like what the Equality Act says, and what the Workplace Race Equality Standard or the Workplace Disability Equality Standard says within the NHS, what we should be doing in terms of long-term people plan in the NHS. It's all well and good being aware of what it says that we should be doing on paper, but does that necessarily translate to being pragmatic about the way in which we care for our patients? No, there's this disconnect between the guidance and being aware of what we should be doing versus how that actually pans out in terms of being clinical facing. So we have, for example, done some training, and we do have a course actually on it, on people who aren't working in patient facing roles but who are non-clinical, because again, front desk when you're a receptionist, if you meet somebody and you misgender them, you use the wrong pronoun, or you say something that's non-inclusive and offensive, if you are non-inclusive of somebody with a learning disability, for example, this has a significant impact on patient outcomes. And so we really need to be aware of the subtleties of language that surround it, and it's something that I hope that we've explored well in the courses and tied it in. We had a wonderful example the other day of somebody who of a practitioner who was describing using an idiom with a patient who had a learning disability, and the patient had presented and was complaining of a headache, and the practitioner said, "Oh, you've got this blinding headache, that must be really problematic." And the patient, when they went home, said to their parents that the practitioner said that they were going to go blind as a result of their headache. And it's an example of how language can become distorted, and how if we use language that isn't inclusive, even of people with learning disabilities, for example, we can cause fear, we can cause upset, we can cause distrust, we can have a massive impact on their clinical outcomes. So that was just a wonderful little case study. Well, not a wonderful, but it was a case study of an example of how our language can have a wonderful learning point, for example. So that's something that I think was really, really, really interesting. So I know many of you are already on these courses, and I hope that you find them helpful. So that's everything that we wanted to talk about this evening. But as we've mentioned, we're going to pop now into the chat just so that we've answered any questions that might be in there. But that's something. So yeah, Beverly, for example, I don't like being referred to as a patient. I think that's really, really important. And we used to see this a lot when we were talking about patient-centered care. And there's that challenge, isn't there, around if you refer to somebody as a patient, the position, you automatically create this concept of being a sick person, of being somebody who is unwell and who is in medical need. So I tend to not use the term patient-centered care. I tend to use the term person-centered care. But unfortunately, there's still this move towards it. It's just something that I've worked really hard personally to overcome, because it is something that I do think is challenging, is the use of language to describe our patients. Bridget, you're quite right. The English language is really wrought with muddles in terms of idioms and ways in which we've been taught to communicate with our patients. In many ways, we've been taught to use these phrases, these similes.
I used one today, this morning, drawing a line in the sand to someone who English isn't their first language. But I immediately followed up with a description. So if you do make these idioms, just follow it up with an example or description of what you mean, to clarify, absolutely, yeah, and check in that they understand if it's to do with diagnosis or something like that. Really important.
Yes, one really, really interesting example of that kind of thing was a patient who had presented to they were in an oncology service, and they presented for they were having what we would term their report of findings, and the practitioner said, well, there are some positive findings as a result of your scan. And of course, a practitioner, the oncologist, meant that actually there was evidence that there was cancerous processes within the body, but the patient's take-home message was that it was a positive outcome. So it might seem in many ways like there is no possible way of getting this right when it comes to inclusive language, when it comes to clean language, for example, of using language that is not confusing for people for whom English is not a first language, when it's for somebody who might take things very literally. So for example, a person with autism or an autistic person might take what we say very, very literally. So it's really, really important to bear that in mind. So Jade, what are your thoughts about using questions around preferred pronouns, etc., on forms, or is it better to ask these questions face to face? We don't use the in terms of pronouns, a lot of people say about preferred pronouns. So just a learning point is we tend to just ask what people's pronouns are, because sometimes saying preferred pronouns implies that there's a choice in it. So for somebody like myself, if I was referred to as they, them, they're not my pronouns. So, you know, I don't have a preference as to whether I'm they, then, or she, her, I am she, her. I would suggest that in using them on the forms is an important signposting technique, really, really important signposting technique, because particularly, again, to talk about the LGBT community, within the LGBT community, people do their research. They research whether a clinician is LGBT friendly, whether a practice is LGBT inclusive, and they look for signposting. So do you have an inclusivity statement on your website? Do you have LGBT practitioners within your clinic? Do you have people's pronouns displayed on the website, for example? These are all little signposts to show that you're an inclusive practice. So having an inclusive intake form where you have a section where a patient can self-describe their pronouns, where they can list what their pronouns are, is an important signposting way to show that you are an inclusive practice, even if the patient doesn't choose to report those pronouns, even if they don't choose to put anything. I would always recommend that you have them on your forms anyway.
A great example actually that I think a lot of people could relate to is when you've got your sort of Miss, Mrs. So I'm talking to the females of the group here. If you are married or were married, so Ms. as well. So I don't know if that's an easier way of thinking about it. So if you've been Mrs. So for example, when we were married, I was still being called Miss sometimes for some reason. I guess because of my age. That's my assumption anyway. But if you don't sort of, if you make those assumptions about someone's pronoun, then it is their identity, it is what it is. It's not a preferred,
yeah,
like I haven't just married, I'm Mrs. sort of thing.
So including it on your intake forms, absolutely. We do have an example of an inclusive intake form, and we do have kind of best practice guidance within the course on the LGBT course, for example, because that is something that I think could be really problematic as a clinic, as well as guidance on how to create an inclusive space within your clinic. Bridget, I love your example there about cutting off your nose to spite your face of somebody with a nose deformity. Rhiannon actually spotted one in a research article today where it was talking about somebody, it was talking about the deaf community, and then said making sure that these patients feel heard. And we both kind of sat there thinking, ooh, is that inclusive, or is it, we understood what the researchers were getting at, but it was an example of actually, if you were in a patient-facing situation, that would be an example of where you might have to go, oh gosh, sorry, I didn't mean that, how that came across. So it's just really something to bear in mind. Now, I don't want to keep you all any longer because, you know, we could talk about this for hours, let's face it, because it's what we do. But you've got our details. All of our details are listed on the page in front of you there. So if you have questions and you want to reach out to us, or you've got specific queries, please do feel free to drop us an email or to find us on Facebook, for example, if that's easier, because we're always very welcoming of questions. All of the, I should add that all of the research articles that we've talked about here this evening, we will put on a document so that you can access them, so that you can read them yourself, so that you can access the research that we've used to create this talk, and you've got that to come back to. We'll also have a recording of this that will be made available to you, and we'll send that out to you via email at a later date. I won't say that it will come this evening, because we do have a toddler who's behaving herself
Not
very well and has
sleeping very
slept
well
through.
at the moment.
But we will get it out to you as soon as we possibly can. So please do look out for those. And please do connect with us in the future. We don't currently have another plan to run a free CPD webinar like this, but we do have lots of ways in which you can continue to learn with us if this is something that you are keen to learn more about. So thank you all to everybody who's joined us this evening, because we really appreciate the amount of you who've come, who've given up your evening to learn about this, and we hope that you found it helpful.